Madam, you are live now.
Okay. Good evening. This is Dr. Sonal Mehta. I am lead medical advisor in INTAS. And INTAS, as you know, is a leading pharma company having its strong presence in fertility business. Continuing the commitment for the scientific update and to engage you all during the COVID-19 outbreak, INTAS Women Health team, headed by Mr. Satyati, have organized this webinar. I welcome you all to this webinar on role of hormonal testing in infertility given by Dr. MANISH BANKER. You are all are requested to put your questions through the chat box. Dr. MANISH BANKER is an infertility specialist, director, Nova IVI Fertility and Pulse Women Hospital. He is past president, Indian Society of Assisted Reproduction, recipient of the Professor B.C. Roy Award 2018, chairman, Infertility Committee, FOXY, regional representative, International Committee for Monitoring ART, member Surveillance Editorial Board IFFS, founder member Aspire, and member Draft Committee of ART Bill ICMR. Dr. Banker has delivered numerous orations and talks at international and national conferences, has to his credit numerous publications, and has contributed many chapters to the books. With this, I welcome Dr. Banker sir to begin the webinar. Over to you, sir.
Good evening, and it's my pleasure to be a part of this webinar organized by INTAS Pharmaceuticals. What I will be covering over the next 40-45 minutes is what is the role of various hormonal evaluation when you are evaluating an infertile couple. So we will look at which hormone to evaluate, when do you evaluate, and what is the rationale of carrying out that particular hormonal evaluation. The hormones that I will be testing or taking you through is TSH, prolactin, FSH, LH, estradiol, progesterone, AMH, and androgens. So let us start with TSH first. Or before that, a few words on how the hormonal interplay happens during a menstrual cycle. The main two hormones in the follicular phase are FSH, which is responsible for the selection, recruitment, selection, and dominance of the follicle, and estradiol, which is produced by that particular developing follicle. Around the mid-cycle, it is the LH which is responsible for the process of ovulation. There is a mid-cycle LH surge, and subsequent to ovulation, the estrogen and progesterone, predominantly progesterone, is secreted by the corpus luteum, and this prepares the endometrium for accepting a fertilized egg or the embryo. Now, the first of the hormones that I'll be discussing is TSH. Now, this is produced by the acidophilic cells of the anterior pituitary gland. If it is not secreted in sufficient amount, it can lead to anovulation and hypothyroidism, or if there is a deficiency of the thyroid hormone, it causes increase of TRH release from the hypothalamus, which also leads to the stimulation of prolactin release, and this inhibits the release of the GnRH from the hypothalamus and subsequently the gonadotrophins from the pituitary, leading to anovulation. So it all works at the level of hypothalamus and the pituitary, and severe hypothyroidism can lead to complete anovulation. Now, when you think about measuring the TSH levels, it should ideally be measured in the fasting early morning sample. If we measure it immediately postprandial, that could be a false suppression of the TSH level, and this also shows a mild diurnal variation. Now, the normal range in a non-pregnant woman is between 0.54 to 5 milli-international units per liter. Now, during pregnancy, HCG stimulates TSH activity, suppressing its secretion. And since the levels of HCG decrease as the pregnancy increases, the level of TSH follow a reverse trend, and it increases as the pregnancy progresses. The ASRM guidelines mention that for the first trimester, the TSH should be below 2.5, in the second trimester below 3, and in the third trimester it should be below 3.5. Now, despite 95% of the population having a TSH of below 2.5, the issue is whether we should treat women who are asymptomatic and have values between 2.5 to 5, which is the normal range for a non-pregnant woman. Because the risk here is that if you overtreat these women and you cause oversuppression of TSH, it could lead to actual bone loss. Now, for women who are attempting the pregnancy, there is a reference range between 2. At least below 4, preferably between 2.5. Some people do recommend the use of low doses of thyroxine for treating these patients of potential subclinical hypothyroidism. But whether to use this cutoff as 2.5 or 4 for women attempting pregnancy is still controversial. So what the ASRM guidelines mention on about treating of women with subclinical hypothyroidism is that it is reasonable to treat even though the evidence is weak. So how does untreated subclinical hypothyroidism lead to infertility, or how are they two linked? Now, there is very limited data according to various definitions of subclinical hypothyroidism that is used. It is thought that the incidence of subclinical hypothyroidism in infertile women and in the general population is more or less similar, though the mean TSH levels may be slightly higher in infertile couples. The prevalence of subclinical hypothyroidism is higher in women who have some form of ovulatory dysfunction or have unexplained infertility. It means that infertile women who have ovulatory dysfunction or who have unexplained infertility, it might be wiser to check for subclinical hypothyroidism and keep their TSH below 2.5. There is also a fair degree of evidence that subclinical hypothyroidism, meaning TSH of around 4 or marginally higher, is also associated with a higher miscarriage rate. And there is good evidence that if you treat women having TSH of above 4, it leads to improvement in pregnancy outcomes by lowering the miscarriage rate. But whether to treat women in the range of 2.5 to 4 in terms of improving their pregnancy outcomes or miscarriage rate, again, there is very little conclusive evidence. However, it would still be safer to err on the safer side and treat these women. Second issue is that of anti-TPO antibodies and infertility or adverse pregnancy outcomes or recurrent pregnancy loss. Now, there is good evidence that thyroid autoimmunity is associated with repeated miscarriages, and there is fair amount of evidence that it is also associated with infertility. So for these patients, it is advisable to treat them with low doses of levothyroxine, especially so if the TSH is about 2.5 MIU per. So this brings us to the basic question as to in which patients would you measure the TSH levels? First, as I had mentioned, all infertile women who have menstrual irregularities, anovulation, or unexplained infertility, because the chances of hypothyroidism, clinical or subclinical, is higher in this category of patients. It should also be offered to patients who have some symptoms of hypothyroidism in the form of weight gain, loss of appetite, lack of concentration, easy fatigability, dry skin, or drowsiness. So opioids, symptoms of hypothyroidism, menstrual irregularities, anovulatory cycles, and unexplained infertility. These are the patients in whom one should measure the TSH. We then move on to the second category of hormones, and that is prolactin. Now, prolactin is a peptide hormone which is produced by the acidophilic cells of the anterior pituitary. In a patient who has got infertility, if the prolactin levels are higher, this can lead to a shortened or an inadequate luteal phase, anovulation, and if very severe, also hypogonadotrophic hypogonadism. Now, hyperprolactinemia causes anovulation or amenorrhea because of the inhibition of the normal hypothalamic GnRH pulse rhythm. If the GnRH pulsatility is disturbed, the effect of this on the pituitary for the secretion of FSH and LH is also disturbed, and this leads to low levels of gonadotropin. And if the hyperprolactinemia is minor, it will simply lead to a shortened or an abnormal luteal phase. If it is more severe, it will lead to anovulation. And if it is still profound, it will lead to complete hypogonadotrophic hypogonadism, depending on the extent to which the gonadotropin secretion is. Now, the normal range of prolactin is somewhere below 20 nanogram per ml. If it is mildly elevated and is in the range of 20 to 50, it will only cause a short luteal phase due to a poor preovulatory follicular development. With moderate elevations up to 100, it can cause oligomenorrhea or amenorrhea. And when it is severe or above 100, it will lead to severe hypoestrogenism and hypogonadism. When these prolactin levels are above 100, a brain scan is mandatory to rule out pituitary adenomas or microadenomas. Now, prolactin needs to be measured in a very specific fashion because its concentration is affected both by food and by sleep. So the ideal time is maybe about 2-3 hours after the patient has woken up and not on a full or a. It is also important that a single elevated reading should be reconfirmed, and patients who have very minor elevations should also have multiple serum assays or a pooled sample before you start treating the. Prolactin could be falsely elevated by a breast examination, and this sometimes forms a part of a gynec examination, and if the patient gives the blood immediately after that, the prolactin levels could be high. It is extremely vulnerable to stress and exercise, but most importantly, it is elevated by a number of drugs and number of very commonly used drugs like antacids. If the patient's prolactin is high, a very detailed drug history should be taken because the patient may not think it important enough to tell that she's taking a drug for another condition, which can lead to an elevated prolactin level. So, when will you evaluate the prolactin in a woman who has got infertility? Obviously, if she has menstrual irregularities, anovulatory cycles, galactorrhea, or symptoms of a prolactinoma like headache or visual disturbance. The normal range would be between 2 to 20 nanogram per ml. Now, how frequent is this in women who have got infertility? It is fairly high. About 15 to 17% of women with infertility have hyperprolactinemia. Secondly, it is a very easily correctable condition. Simple medications in the form of cabergoline or bromocriptine are sufficient, and you are actually treating a cause. Hence, the results are very encouraging. Patients who have ovulatory disturbances will start ovulating within 6 cycles of starting the therapy. Sometimes hyperprolactinemia women might require a higher dose for ovulation induction or may also have cycle cancellations due to poor response. Secondly, if it is elevated, it might also negatively impact the endometrium because the estrogen levels are lower if the prolactin levels are higher. Now, what should you do once a patient who has had hyperprolactinemia becomes pregnant? Now, there is no evidence that cabergoline or bromocriptine have any teratogenicity. Also, there is no increased risk of abortion or multiple pregnancies. The guideline is in the absence of in the absence of a prolactinoma, it should be discontinued. If the patient has a prolactinoma, the tumor size is less than 10 millimeters, again, it should be discontinued because the risk of tumor expansion is very low. It is only when the adenoma was more than 10 millimeters, the bromocriptine should be continued to avoid the risk of tumor expansion. Every pregnant patient who had a prolactinoma should be evaluated every 2 months during pregnancy. We cannot monitor with prolactin levels, but ideally they should be with the help of visual field testing because this is the earliest sign that one might have if the prolactinoma is increasing in size. If the visual field defects develop during pregnancy, despite the patient being on a dopamine agonist therapy, then one might have to resort to early delivery or pituitary. The third hormone that we shall now be discussing is follicular stimulating hormone, or FSH. Now, FSH is a glycoprotein produced by the anterior pituitary in response to GnRH. Its primary role is in folliculogenesis. It rescues and recruits small preantral follicles from undergoing apoptosis. How do you measure the FSH levels? It is very important that it should be measured in conjunction with estradiol to interpret the results accurately, because an elevated estrogen level can falsely suppress the FSH level. So it should never be measured and interpreted alone. One should always get the estradiol done at the same time. Secondly, it should always be measured under basal conditions, that is on the second or the third day of the menstrual cycle, as it fluctuates a lot throughout the menstrual cycle. The normal range under the baseline condition is between 3 to 20 international units per liter. The question then is, why would you evaluate FSH? What inference does the FSH give you when you're treating an infertile woman? The first and the foremost role of FSH is when you're evaluating a woman who has anovulation with or without amenorrhea. This helps in classifying the patient as to in which of the WHO categories does the patient fall. And this will then decide the type of treatment to be offered and to give an accurate prognosis. The second role is to measure it to test the ovarian reserve. And third is to find out the degree of pituitary suppression or downregulation before you start the stimulation in a long agonist protocol. And let us look at these three one by one. Now, if you look at the WHO classification of anovulation, this is primarily based on how the FSH and estradiol levels are. Both the levels are low FSH, low estrogen. It means that there is decreased secretion of FSH from the pituitary, and hence the ovarian estrogens are also low, and this goes in favor of hypogonadotrophic hypogonadism. If both the levels, FSH and estradiol, are within normal levels, it suggests normogonadotrophic hypogonadism, and the commonest cause of this is polycystic ovarian syndrome. Whereas if the FSH levels are significantly elevated, whereas the estrogen levels are low, it suggests a hypergonadotrophic hypogonadism, which means that the primary cause is in the ovary. The ovary is not responding to this high FSH, hence the estrogen levels are low, and the pituitary compensates by secreting more and more of FSH. And this points out to premature ovarian failure. This is the primary role of measuring FSH, as to which of the category does the patient fall into, depending on whether it is extremely low, normal, or significantly elevated. In terms of ovarian reserve, if the normal range is up to 20, the ideal value under baseline conditions should be less than 10, ideally less than 9. This would recommend a normal ovarian response to ovarian ovulation induction. If it is even marginally elevated above its midline values, up to 12, even this favors a reduced ovarian reserve. But the moment it is above 12, and especially above 17, this suggests a marked reduction in the ovarian reserve. So even though the normal values are up to 20, value of above 12 or any value in double digit is an early sign that the ovarian reserve is already declining. There is another issue regarding the variability of FSH levels, that if it is elevated in one cycle, should we repeat it in the next cycle? And there is evidence that a single elevated FSH level in a young woman may not necessarily predict a poor response to stimulation or failure to achieve a pregnancy. And there is some evidence which also suggests that if the FSH levels are elevated, one can measure it in every cycle. And in a cycle where the FSH level has fallen even marginally, we should pick up that cycle to start ovarian ovulation induction or ovarian stimulation. But how accurate is FSH in predicting ovarian response? This is a very good part from the ASHRAE guidelines, which tells us how accurate is the FSH for predicting ovarian response. And what they've studied is the area under the curve, looking at the FSH levels and the number of follicles that one would retrieve. If you look at from this study, the area under the curve for FSH is 0.66, which is not very high. A good value should be 0.8 or higher. So what these guidelines concluded that the prediction of ovarian response categories by basal FSH alone is not sufficiently reliable. So the value of FSH today is more for classifying the patient into which category of anovulation does she fall in. As far as its role in predicting ovarian reserve, it is not sufficiently reliable. The next hormone that we shall be look about is LH or luteinizing hormone. Now this is also produced by the anterior pituitary in response to GnRH analog. It is important for two functions. One, for the production of steroids from the ovary. Second, the mid-cycle LH surge is responsible for the final ovulation or initiating the ovulation. The LH surge starts approximately 36 hours prior to ovulation and it reaches a peak 12 hours before ovulation. As you can see from the normal ranges of LH, there are huge fluctuations from as low as between 2 to 15 during the follicular phase, as high as in the range of 100 around the time of the mid-cycle ovulation. This is a hormone one needs to be very careful about when we are monitoring this. It is also now known that the receptors for LH expression are present on the follicles when they are extremely small. When a growing follicle or when the granulosa cells are less than 5 millimeters in size, they do not have any receptors for the LH. The moment they cross the 5 millimeter size, there is expression of LH on the granulosa cells. And by the time they are more than 10 millimeters, most of them have receptors for LH. This means that LH plays a significant role in the follicular development as well, contrary to what was believed earlier, that the early follicular development is purely FSH dependent. It is not so. Even early folliculogenesis requires a minimal certain amount of LH. So the question now again is, when would you measure the LH? What inference will you get from measuring the LH levels? It has three aspects to this. One is a diagnostic. Similar to measuring the LH on the FSH on the day second to classify the patient into a type of anovulation. Measuring the LH also adds value because in patients with hypogonadotrophic hypogonadism and in premature ovarian failure, LH will more or less mimic the FSH. It may be measured on the day second or third to confirm pituitary downregulation, but here estradiol is a much efficient marker and hence this is not carried out. It is in some countries very popular to measure either serum or urinary LH to predict the day of ovulation. Patient can do this testing once or twice in a day as she reaches the pre-ovulatory period. But today in our country, ultrasound is much more efficient and much more commonly used to monitor. But there are two recent uses of measuring the LH in a woman who has infertility. One is on the second or the third day of the cycle, look at the degree of suppression of the hypothalamo-pituitary axis. And second is to monitor the efficiency of the GnRH analog trigger in an antagonist cycle. And I shall take you through both these indications in more detail. Now, to expand on this, at once upon a time, the LH to FSH ratio being more than 2:1 was thought to be a cardinal a feature of polycystic ovarian syndrome. And after the introduction of the Rotterdam criteria, this is now no longer being considered. Diagnose hypogonadism, as I had mentioned, along with the FSH. If the LH is low, it does help. For pituitary downregulation, estradiol is the most important hormone, and hence LH is not regulated. To detect a premature LH surge, it is not carried out, but to detect the day of ovulation, you could use this LH case. But as I mentioned, the two major upcoming roles are after to monitor the response. Now, there is increasing evidence coming on that the LH levels at the baseline condition are important or very relevant to predict whether the response to an agonist trigger will be optimal or suboptimal. Now, if after giving an agonist trigger, if the LH rise is not adequate, we will either not retrieve any eggs, leading to an empty follicle syndrome, or we will retrieve very fewer than normal eggs. And it has been found that if you measure the GnRH, the LH levels after a GnRH agonist trigger, the value has to be 15 or above 12 hours after the trigger. If you're giving the trigger, you can monitor the LH levels 12 hours after the trigger. And if the rise is suboptimal, it will give you the earliest warning sign that you are either heading for empty follicle syndrome or you will have fewer than the expected number of oocytes. It has been shown that this has a nearly 25% risk of a suboptimal one. What about measuring the LH at the start of the stimulation? Now, this is a very interesting concept. What the LH level is at the beginning of the cycle is a surrogate of a pre-treatment pituitary LH pool. And this represents the amount of pituitary LH that will be available for secretion once you give a GnRH agonist trigger. Hence, if the LH levels are extremely low at the beginning of the cycle, your agonist trigger is unlikely to act very efficiently and will lead to a suboptimal oocyte. Now, why does this happen? The commonest cause for this is long-term or indiscriminate use of oral contraceptive pills. If the patient has been on oral pills, the FSH and LH values should normally be restored after 5 days of discontinuing these pills. But sometimes when you start to stimulate these patients, it takes a longer amount of time and requires a higher duration. And a small percentage of patients will continue to exhibit low LH levels or LH suppression even after 5 days of stopping the oral contraceptive pill. It is also shown that the first LH surge that happens after the prolonged OC pills is also inferior. So maybe the first cycle after discontinuing the pill is also not ideal if you are planning a agonist trigger. And this is the paper from the Brussels group, which has looked at the predicted oocyte yield following an agonist trigger by measuring the serum LH level at the start of the stimulation. What they have shown is that the probability of suboptimal response increases with a decreased LH level. If the LH levels are less than 0.1, then the risk of having a poor oocyte yield is 45%, whereas if it is less than 5, the risk decreases to 13.6. So not only is it predictive, there is also a quantitative correlation. Lower the LH on the second day, poorer the oocyte yield after an agonist trigger. But mind you, this is only with an agonist trigger. If you're giving a HCG trigger, then it does not make sense in measuring the LH levels. So there are two levels we need to measure. One is the baseline, and second, post the trigger. If after the trigger, the LH is more than 12 or more than 15, then it suggests an adequate response. We now move on to the next hormone, and that is serum estradiol. Now, estrogen is secreted predominantly in the form of estradiol, by the granulosa cells in response to follicular stimulating hormone. Now, the primary function of estradiol is to modulate the course of the menstrual cycle by inducing endometrial proliferation. During the second half of the cycle, after ovulation, along with the progesterone, it prepares the endometrium for the incoming embryo. Now, again, where do you measure the cycle? The hormone. If you are measuring it under baseline conditions, and if it is elevated, then one should look at in conjunction with FSH. What people feel is that a low FSH with a high estradiol is possibly a false suppression of FSH by this elevated. What is the normal estrogen estradiol value? It ranges from between 150 to 200 picogram per ml per mature follicle of 16 millimeters and above. So when would you measure the estradiol? What is its clinical relevance? First, again, on the second or the third day of the cycle, along with FSH to determine the cause of anovulation. Again, we go back to the WHO classification. If both are low, it is hypo-hypo. Both are normal, more in favor of PCOS. High FSH, low estrogen, premature ovarian failure. Second, it is used to confirm pituitary downregulation in women on the long agonist cycle. For monitoring, it is used to monitor the response to ovulation induction or to controlled ovarian stimulation in IVF ICSI cycles, or it can also be measured on the day of the trigger to assess the risk of ovarian hyperstimulation syndrome. And let us see what is the evidence on all. Now, estradiol levels measurement on the second or the third day, as I mentioned, is one to confirm pituitary downregulation in an agonist cycle. But when the patient is not under any kind of suppression, or the patient has not received an agonist suppression as in the long agonist protocol, if the estradiol is higher on the second or the third day, it generally signifies the presence of a simple follicular cyst, which can then be confirmed by an ultrasound. People have also tried to predict the outcome to stimulation based on the estradiol levels on the second day of the cycle. But there is inconclusive evidence as to at what levels is the response poor, and hence the ASHRAE guidelines mention that one should not measure estradiol levels on the second day to predict the response to ovarian stimulation. And these are various studies which have been used as supporting evidences based on the basal estradiol. They've tried to predict whether the ovarian response will be normal or adequate or high or low, and it is concluded that the basal estradiol alone is not a predictor of ovarian response. Now, how do you monitor the estradiol cycle, and what is the role by doing it by only estrogens? It was very important before 1991, where the experience with transvaginal ultrasound was extremely low. Now, as clinicians are increasingly using TVS to monitor follicular growth and endometrial thickness, the need for serial estradiol monitoring has declined. Here again, the word is serial estradiol monitoring, because ultrasound scanning is the method of choice as it is practical, reliable, non-invasive, and cost-effective. But what about measuring the estradiol level during the cycles? There is no defined upper or lower limit at which the cycle should be altered or cancelled. It was earlier believed that if you measure the estradiol after 4 or 5 days of stimulation, it will give us an idea as to whether follicular recruitment is happening adequately or not. But here again, with the quality of ultrasound machines improving, ultrasound forms the mainstay of predicting the response to ovulatory drugs rather than estrogen. And this is a very good paper which looks at the use of ultrasound along with estradiol. It is the evidence comes from 6 RCTs looking at 800 women, and it concluded that by measuring the serum estradiol level along with ultrasound, it did not appear to either decrease the probability of OHSS or increase the probability of pregnancy or the number of sites reached. So in short, adding estradiol monitoring to the ultrasound monitoring, which is commonly done, does not add value. So the addition of estradiol measurements to ultrasound monitoring is not recommended. What about the estradiol levels on the day of the trigger? Here again, the evidence from the ultrasound, which shows the number and the size of the follicles, far superior than what the estradiol level is, because the estradiol levels keeps on varying depending on the size of the growing follicles, the distribution of follicles of having different sizes, and hence it is not a very reliable predictor deciding as to whether a freeze-all or a normal fresh transfer should be carried out. We then move on to the next hormone, and that is serum progesterone. Now, progesterone is a steroid hormone which is produced by the corpus luteum and in small amounts by the adrenal glands as well, predominantly as 17-hydroxyprogesterone. It induces secretory changes in endometrium to prepare the uterus for implantation. The normal values in the follicular phase are less than 1.4 because it is negligible, and post-ovulation between 3 to 20, ideally above 5 or more commonly above. The question then is when and why should you evaluate the progesterone level? One, we can measure it in the mid luteal phase of the cycle, that is approximately 1 week before the date of the next expected periods. And this helps us in defining whether the ovulation is adequate or not. And if not, it gives the diagnosis of luteal phase defect. It can also be done to confirm adequate pituitary downregulation or to rule out functional corpus luteal cysts if you see them on the second or the third day of the period. What about measuring progesterone as a part of monitoring? And two aspects. One, the importance of baseline progesterone levels, that is P4 on the second day of the period before you start the stimulation. Secondly, before the trigger to detect premature luteinization or premature progesterone. For confirming ovulation, it is 1 week after presumed day of ovulation, that is day 21 of a 28-day cycle. A single value of more than 10 nanogram rules out corpus luteal deficiency. If you want to do it to measure adequate downregulation, it should be less than 0.5. But again, serum estradiol levels are more commonly used to measure pituitary downregulation in a agonist. What about measuring progesterone levels before cycle initiation? It has been shown by these two papers that progesterone may remain elevated at the time of menstruation in between 5 to 6% of patients. There is some evidence that if it is significantly elevated, more than 1.5 or 1.6 on day 2 of the cycle, there is a 15% decrease in the probability of an ongoing pregnancy. Hence, there is again some evidence coming in that this would help us identify patients in whom the pregnancy outcome could be compromised. What about progesterone elevation in the mid-cycle or around the time of the HCP trigger? Now, there are two terminologies here. One is called premature luteinization. This means there is a rise in progesterone because of a premature LH surge. Now, this is unlikely to occur in a properly downregulated cycle, whether an agonist or an antagonist. This is something which is uncommon, but could be one of the reasons. The second and the more interesting is that of premature elevation of progesterone or premature progesterone rise, which occurs even in the absence of a LH surge. So this is not an LH-driven activity, but the progesterone rises due to something else. And how does this happen? Let us go back to the physiology. The FSH from the pituitary acts on the granulosa cell. It helps in conversion of cholesterol to progesterone. The LH acts on the theca cells and it helps converting this progesterone, which comes from the granulosa cells, into androgens. So the progesterone secreted by the granulosa cells in response to FSH is converted in the theca cells to androgens by the action of LH, and androgens eventually to estrogens. LH plays a very important role in converting the progesterone into androgens and subsequent estrogens. Now, when you induce multiple follicular developments by predominantly FSH stimulations, you have a very high level of FSH, which is not balanced by an appropriate LH activity. More so if the day 2 LH of the patient was already low. So what happens in this scenario is, since the LH is low, it is unable to convert the progesterone from the granulosa cells into estrogens, and hence there is an elevation of progesterone. This is what is called premature progesterone rise. It is in fact because of exactly the opposite, because of the low LH and not a high LH, which is the reason for premature luteinization. And this is common in predominantly in only FSH or high FSH stimulations in patients who have low intrinsic LH. There is sufficient evidence that if the progesterone is elevated on the day of the trigger, the pregnancy outcomes are not good, because here the endometrial receptivity is advanced because the endometrium is exposed to high levels of progesterone earlier than when it ideally should be. This is the earliest paper from Santos Ribeiro looking at pregnancy rates based on progesterone elevations. And you can see that as the progesterone starts to go above 1 and more above 1.25, 1.5, the pregnancy rates or the live birth rates. A word of caution is that we should not take this progesterone cutoff values from what has been published, because the progesterone assays that your lab would be using could be different, and we should all have our own cutoff values above which we will think of converting the cycles into free zone. But most studies put this value at either 1 or at 1.5. Second last hormone that we would be looking at is the anti-Mullerian hormone. Now, this is a glycoprotein which is produced by the preantral and the early antral follicles. Its action is inhibiting the development of the Mullerian ducts in the male embryo. It is measured by multiple assays available, the Beckman-Coulter, the Roche, numerous assays. Now, this is a marker of ovarian function because it is predominantly secreted by the primary and the preantral follicles, which are FSH independent. These are not FSH dependent. So AMH acts on the follicles before the action of the FSH actually comes in. It is a very promising candidate for measuring the ovarian reserve, but still we know that there are many factors which can influence the AMH concentrations, and this include weight, obesity, ethnicity, vitamin D status, polymorphism of AMH, various genetic variants, and possibly smoking as well. But the clinical relevance of all these observations need to be. The normal value for predicting ovarian reserve in terms of nanograms, it is between 0.2 to 0.7. Any value below this is suggestive of a diminished ovarian reserve. But as I mentioned earlier, we should also acknowledge that AMH is also variable. It could be variable because of the biology, because of the exposure to various medications or how the sample has been exposed, or by the laboratory technique. And if only one source of variability is affecting the AMH value, a value of 1.5 could be detected as low as 1 to a maximum of 2. But if all three sources of variability are combined, a real value of 1.5 could be measured as low as 0.5, 0.5. So it is not the answer to all measures. This also has some variability. So why do you evaluate the AMH? Because it helps in deciding the appropriate treatment for infertile women, to predict the dose required for ovarian stimulation, and to offer some sort of prognosis. So based on the AMH levels, you could stratify the patient as a normal responder, high responder, or an excessive responder, or a lower responder. Start a stimulation protocol, a mild strategy antagonist, mild strategy antagonist, here agonist trigger, here HG trigger, long protocol, or a flare based on what the AMH and the age. The AMH is more sensitive in predicting a poor response and an excessive response. That is, at both ends of the spectrum, AMH is more sensitive. This is because the area under the curve for predicting a poor response and an excessive response is fairly good if we measure AMH. This is the orange curve, which is the AMH, and here you can see the AMH curve. So if you look at the HRI guidelines, along with the antral follicle count, AMH shows a very high accuracy in predicting both a low and a high ovarian response, and they should be measured before you start the stimulation of the. This then brings me to the last category of hormones, and these are the various androgens. You have various androgens. From the adrenals, you have DHEA and DHEAS. From the ovary, you have androstenedione. From the adrenal and the ovary both, you have testosterone. Now, most of the circulating testosterone is produced by peripheral conversion from androstenedione to testosterone. And this again is important for ovarian steroidogenesis. Now, when do you measure the samples and how do you do it? Again, it should be done between 8 and 10 in the morning, somewhere 8 days after the onset of menstruation. Though the blood for DHEAS can be collected at any time because it does not vary significantly. These are the normal values of all the hormones: DHEA, androstenedione, total testosterone, and free testosterone. But the more relevant question is, when will you measure the androgens? All women who have hirsutism, especially if it is severe or rapidly progressing, one must measure the androgens. Or if the patient has other signs of masculinization like clitoral hypertrophy, hoarseness of voice, or a male pattern of baldness. These are the patients who should have an androgen evaluation. It is also used to establish the cause of androgen excess, because you could have patients who have late onset congenital adrenal hyperplasia or adrenal tumors. In this, 17-hydroxyprogesterone and the androgens both will be elevated. What about women with polycystic ovarian syndrome? Here, if you look at the Rotterdam criteria, even if the patient has clinical features of hyperandrogenism, you don't need to measure the serum androgens to classify the patient as having PCOS. Secondly, if you want to measure, free testosterone is the hormone that should be. In addition, what about measuring the hormones in male infertility? There are 3 hormones which are relevant: FSH, LH, and testosterone. And in normal men, all 3 would be normal. If there is testicular failure, primary testicular failure, FSH and LH would be high, testosterone would be normal or low. If there is hypogonadotrophic hypogonadism, all 3 will be low. And if there is an isolated spermatogenic failure or focal hypospermatogenesis, the FSH could be mildly elevated, but the other hormones are completely. So I would end by summarizing which hormones should be evaluated. TSH, yes. Prolactin, yes. I have gone through the special indications for this. FSH again, yes. LH, maybe. Some evidence that measuring it at the start or before, after an agonist trigger could be of value. Estradiol, definitely yes. Progesterone, again yes. AMH, also a big yes. So these are the hormones that you would measure in a patient who has got infertility. Androgens may be under very specific conditions. I thank you all for a very patient hearing, and let us see the questions or any questions that we have on this.
Thank you, sir, for taking us through the basic infertility investigation to the complex IVF monitoring and all this, and making it very simple. There are many questions. I will be going through some. One is, should TSH and prolactin be measured in all infertile women or only those with anovulatory infertility?
As I had mentioned in my talk, I'm in principle against a blanket screening or what are called infertility panels, because each hormone has some amount of variation. And if you measure it without having a mind as to what you are looking for, marginal values out of range will only end up confusing you. So I would measure them only if there is some suspicion that this would be abnormal, and it would be typically in patients who have either some menstrual irregularities or some ovulatory disturbances, or in couples having unexplained.
Right. What about serum progesterone value with diurnal relationship?
Serum progesterone does not have a lot of diurnal variation, so it can be measured at any time of the day.
Sir, any role of AMH in diagnosing PCOS?
So it has not been used as a criteria for diagnosing PCOS. The clinical diagnosis of PCOS is only based on ovulatory disturbances, androgen excess, and the appearance of the ovary. There are no established cutoff values of AMH at which one should diagnose PCOS. Having said this, obviously it will be higher in women with PCOS, but there is no set cutoff below which you can exclude PCOS.
Right, sir. It is popular dogma that relatively lower E2 levels at the time of trigger yield lower M2 oocytes. Your experience, sir?
So we generally, as a rule, do not measure the estradiol levels on the day of the trigger in all patients. I only measure it if there is a specific indication. This is predominantly in hyper responders or in extremely low flow responders. Only at both extremes do I measure the serum estradiol levels. In all normal responders, estrogen values fluctuate a lot because it depends on the size of all the follicles. You could have two patients, one patient having 6 follicles of 18, and you could have another patient who has got 3 follicles of 18, 3 of 17, and 3 of 16, and the estradiol value in both could be the same. So I would decide this looking at mainly the follicular size and the cohort rather than the estrogen level.
Right, sir. Sir, there is one question. Have you seen a rise in progesterone in patient with LUF as well? If yes, then how does one go ahead in diagnosing it?
Progesterone could be elevated in patients having luteinized unruptured follicle because the corpus luteum has been formed in this patient. So this whole luteinized unruptured follicle is a very difficult condition to diagnose. But one must remember that this condition does not occur in repeat cycles. It is generally an isolated event in one isolated cycle of a patient. It does not tend to recur. It recurs more often in two categories of patients, one with endometriosis and second in clomiphene stimulations. So you need to treat the cause. If it is induced because of clomiphene, you can use other ovulatory drugs.
Right, sir. Should E2 and P4 be measured on day 2 of FET cycle and how to interpret it?
Again, we do not measure the estradiol or progesterone on day 2. What we do is a good transvaginal ultrasound scan. If the endometrium is thin, showing evidence of shedding, and both the ovaries are quiet, estrogen or progesterone will not add value. Only when you find there is something in the ovary, you can measure the E2 or the progesterone. But if you find something in the ovary, it might be wiser to skip the cycle rather than waste money and time on a E2.
Can we completely do away with prolactin measurement if the woman is clinically normal?
Yes, if the patient is clinically normal, completely normal ovulatory without any signs or possibility of abnormal corpus luteum, the prolactin level will be normal. But in women who have got long-standing unexplained infertility, it should form one of your part of your investigation to complete. But otherwise, in a normal patient, I would not measure the serum prolactin every.
Right, sir. Does low AMH affect quality of oocytes?
AMH is a marker or is a quantitative marker of ovarian reserve. AMH will tell you how many oocytes you are likely to retrieve. Quality of eggs depends primarily on the age of the patient. So amongst women with low AMH, if the patient is young, you will get fewer eggs, but their quality will be good. If she is elderly, you will get poor eggs of poor quality. For quality, it is the age. AMH is predominantly quantity.
Should we routinely use estrogen support if we are giving ovulation induction, since endometrial thickness don't grow up till optimum level in few patients of ovulation induction? What is the optimal time if required to add the estrogen support?
So first of all, I think there is no role of estrogen support in any ovulation induction. If the endometrium is not developing well, it is not because of hypoestrogenism. If you are seeing a normal follicle develop and it is a good follicle and the endometrium is not developing well, the problem lies somewhere else. Substituting estrogen from external sources when this endogenous serum estrogen is already normal does not. Two aspects to this. One, this estrogen would actually suppress the FSH and have a negative effect. And two, if the endometrium is not developing, one should look at the cause for this poor endometrium. Is it the stimulation drugs? If you're giving clomiphene. Is it a primary endometrial problem? You should look at the endometrium flow, do a hysteroscopy or do whatever test. But adding estrogen in any form during ovarian stimulation will not do any benefit. It can actually do harm.
Patient planned for FET cycle, and on day 3 cyst present and serum estradiol is 140. How to proceed?
You should cancel the cycle. You can either wait if if she has normal cycles, it will suppress on its own, or you can give her a course of a contraceptive pill and it will disappear.
Correct, sir. What should be done in cases requiring IVF but having prolactin greater than 50? Should we treat and then wait for it to return to normal and then start IVF?
Yes, we should correct the hyperprolactinemia before you start your IVF stimulation because it will interfere in the response to ovulation induction medication, especially when it is above 50. You should correct it. Generally, the prolactin levels fall very fast after cabergoline or bromocriptine therapy. Within a month, they should come down to normal, and you should then start the stimulation.
What should be done if level of LH 12 hours after agonist trigger is less than 15 IU?
So this is a challenge because this will tell you that the surge is likely to be suboptimal. If it is, let's say, between the range of 12 to 15, you should still proceed with your pickup because you will get eggs, you would get fewer eggs. But if it is a completely non-existing surge, values less than 2 or 3, there is a possible role of giving another trigger, this time maybe HCG, and doing the egg collection after the second trigger.
There is one question. Role of serum LH in IUI cycle before giving trigger. What is the acceptable LH value indicating surge if it is required?
I think for an IUI cycle, it is too much because most of the IUI cycles would not be with any kind of suppression. So you will find that the LH surge happens in certain instances, but it is too much to do for an IUI cycle. For an IUI monitoring, I generally don't measure the LH.
This is regarding thyroid. So for all those values is between 2.5 to 4. Should we see for TPO antibodies and decide on treatment?
The TPO antibodies is more related to patients who have recurrent pregnancy losses rather than pure infertility. So if the patient has only infertility, just correcting this is fine. But if she has recurrent pregnancy loss as well, then one should look for anti-TPO antibodies.
Sir, any role of measuring LH on day 2 or 3 in PCOS prior to COS controversial stimulation?
No, this was very popular in the early times when the LH-FSH ratio concept was there. Even if you measure the LH, first of all, it is very fluctuating hormone, so there are no cutoff values. And secondly, no matter what the LH levels are, it will not change your stimulation protocol. So measuring LH primarily for PCOS does not add value.
Sir, question is, what is the size of cyst cutoff beyond which you will defer stimulation if you are not doing E2 on day 2 before stimulation?
There are not many publications looking at this, but we follow anything above 1 centimeter, we will cancel the cycle.
Sir, if this is again same as if LH levels are less than 15, can we do ET in PCOS patient after ovum pickup cycle? Is it possible to do ET without giving leupride depot preparation and OC pill cycle?
I did not understand. Can you repeat the question?
Yeah, sir, the question is it possible to do embryo transfer without giving leupride depot and OC pills in PCOS patients?
Yes, you can do. Agonist suppression or a pill suppression is not necessary for all patients or is not necessary for doing a frozen embryo transfer. What you require is a HRT protocol, estrogen, monitor the endometrium, add the progesterone and do the embryo transfer. You would use a OC pill or an agonist depot only if the patient is not getting suppressed, she escapes this, there is a premature LH surge or there is a corpus luteum, or if she has endometriosis, then it's okay. Otherwise, for routine FET cycles, an agonist depot or a OC pill suppression is not required.
Sir, there are many questions, but I am asking the last one. Role of E2 doubling to assess stimulation response.
Again, this was popular at once upon a time where the reliance on estradiol level was more than on the ultrasound findings. Today, almost exclusively all clinics monitor the patient only with ultrasound. Adding estradiol to this paradigm only adds to the confusion because you will keep on changing and altering the doses based on a hormone which tends to fluctuate based on the cohort of the follicle rather than because you have multiple follicles at different sizes. So I would not monitor the estradiol levels at all during a stimulation, and especially I will never modify the stimulation regime based on the rise in estradiol.
Thank you, sir. There are many questions, but due to constraint of time, I thank you on behalf of all the viewers and on behalf of INTAS for giving us your time and giving us the very nice and I must say, very lucid and explanatory lecture. Thank you, sir.
Thank you. It was my pleasure.
Thank you very much, sir. हेलो लगता है सर चले गए सर फोन कर लीजिए थैंक यू सोनल मैडम
थैंक यू सर एकदम से चले गए
हाँ वो क्लिक किया निकल गया गुड इवनिंग सर, थैंक यू वेरी मच, बहुत अच्छा गया सर सर एक परमिशन चाहिए था, ये वीडियो में सर्कुलेट कर सकता हूँ ना सर?